I think the topic, it fits really well in the session, tools or toys, and we came across to the 3D printing quite recently, just because we had to manage very sick patients in whom we cannot or just reduce the entity of the dye during the procedure, and was almost an end-stage renal failure. And we had just to manage how to properly measure the left atrial appendage, and so we choose to use the 3D printing. Just let me introduce briefly. The 3D printing actually is not new in medicine, because it has been recently used in different fields, and I show you just one slide just to make us aware what is the role of the 3D printing. It's a novel technology that allows to create specific model of any given anatomical portion of the heart, but obviously any given portion of the human body. Is a reproduction with a high fidelity, the virtual model that you can grab for any DICOM file, and you can use a CT scan or even MRI, and it is processed with a customized software. And then there is a polymer. The polymer is make a fluid with a laser process with a high resolution. There's around 200 microns, and this is just a brief description of how it really works in the rationale to use the 3D printing. Just for any individual patient, we can use this tool just to improve the patient understanding, the anatomy, and actually it's really useful just to planning what you have to do or what you deem it's more important just to do in that specific patient. So it might reduce the operating time, and you can simulate any steps, even the more complex steps in advance. And obviously it's right now in the majority of cases used by a surgeon. Here just an example. It's really a brief videos that show you how the 3D printing works in the real world. Okay. It should be nice if it works. Okay, just let's go step forward. The 3D printing in medicine has been recently used, especially in neurosurgery and pediatric oncology, and vascular surgery, and the cardiovascular and thoracic surgery, and also in plastic regenerative surgery. Here, just an example how the neurosurgeon can reproduce with a high fidelity the skull of this patient, and where the surgeon has to operate to excise a tumor in the eye. Or maybe in pediatric oncology, you can just reproduce in a 3-dimension the skull of this baby. And even in a thoracic surgery, you might reconstruct, you might just plan how to reconstruct the ribs or after a crash accident or for any kind of injury. Just for the left atrial appendage closure, regardless the device that you want to implant it, obviously you had just to realize that for any kind of device or the occluder, you had, as already we had mentioned, to establish the size of the ostium, to establish the landing zone and the depth. So even for the more simple cases, we might have patients with a high variability, as we already have learned this morning from the Cabrera lecture. And obviously, we need just to properly understand the anatomic relationship between the left atrial appendage and the surrounding structures. And therefore, the possibility and the opportunity to have beforehand the exact reconstruction and the reproduction of the left atrial appendage may be useful in some specific cases. So we have just a pilot study, and I like just to show you a couple of examples just to make easier the understanding how to use the 3D printing. This is the clinical case of 69-year-old female with a paroxysmal atrial fibrillation, hypertension, and all the clinical presentation that make the patient really suitable for left atrial appendage closure. We also planning just to do PVI isolation first and then the left atrial appendage closure. In this specific case, we use the Coirix Waycrest device. So if we look at the measurement provided by the angiogram and the T, they are almost equivalent. But in the rehearse phase that I show you in a moment, actually the 27 millimeter device provided the best compression, but also the need to retract the device to cover a proximal lobe. Here we have an example in the slide. In the left upper corner, you have the device in the rehearse phase, the 27 millimeter that is positioning really in one of the best position with this kind of device. But we already knew that there was a proximal lobe, and the retraction maneuver was obviously already tested during the rehearse phase. And the maneuver that we had to accomplish during the procedure was just to cover this lobe in order just to have the perfect sealing of the left appendage. Another case, a 42-year-old man with a Marfan syndrome, with a mitral valve angioplasty years before, again with a paroxysmal atrial fibrillation, previous TIAs, despite oral anticoagulation treatment. And again, with the left atrial angiogram, the neck of the left atrial appendage measured between the 23 and 25 millimeter, and the ostium we had the 28, the TE we had the 25 and the 27, almost equivalent. When we reproduce with the 3D printing the left atrial appendage of the patient in the rehearse phase, actually the 27 was unfitted and the 31 was a perfect sealing. Here we have just an example how the 27 was not the best sizing for this patient, whilst the 31, the Amplatzer Amulet, was perfectly fitted. And here we have just one short example how to test beforehand the size of the device when we have the 3D printing of the left atrial appendage. This was again with the Amplatzer Amulet. Now, how to accomplish the printing of the appendage for any other given anatomical element. Here we have the pre-acquired CT scan, so we have the appendage over here. You have just to collect all the information in different views and try just to completely isolate it from the surrounding structure, the left atrial appendage. And again, here we have the perfect 3D reproduction of the left atrial appendage in this patient, just ready to be tested based on the measurement, the perfect design size for the left atrial appendage in this patient. Now, obviously, everybody in the audience could raise a question, why do we need to complicate our life? just because obviously the current modalities of evaluation of the size of the left appendage actually give us a very high success rate. This morning we have listened to different presentations with different imaging modalities in order just to evaluate the size, the depth of the appendage, the relationship between the appendage and the surrounding structures, and then we add something else. Obviously, the more information we had beforehand, the more secure will be, hypothetically, the procedure and the safer for the patient. So, is really true or not that the current modalities of evaluation of the appendage size and morphology is not fully compliant to properly guide the choice of the device? And how often the device is oversized or undersized according to the measurement provided by TE or the angiogram or the CT scan? Are there clinical demands really to completely avoid the use of dye, for example? We have already heard that in some patients it's reasonable not use or maybe limit the use of contrast, and therefore they need to rely on an imaging technique only. At which expenses, cost effectiveness, are we ready and is acceptable introducing a novel technique for left atrial appendage size evaluation? And obviously we need to answer ourselves, is this all is beneficial to patient? Is really go to increase the occlusion rate and to reduce the complications rate? My conclusive remark is that the 3D printing obviously has the ability to reproduce the left atrial appendage morphology, volume, and depth with very high fidelity. 3D printing could be considered a valuable technique to sight the correct occluder in those cases in which, for example, dye or a T are contraindicated. The left atrial appendage angiography can under or overestimate the left atrial appendage measurement. So having a printed model of the appendage is an additional tool for the correct device sizing and for a reliable rehearse of the vestibule, ceiling, and the proximal lobes covering. What about the cost? The average cost for each reproduction is about 300 euros. That means almost 300 US dollars for 2 hours printing time. To this, you had to add the cost of the printing that, it can go from 1,000 euros to 20,000, 30,000. It depends on your need. If I have time, I have just a couple of questions just to ignite the discussion. So, based upon the data that we have, really few data, but is there a role for you that 3D printing in a left atrial appendage occlusion procedure? A, yes, the current technology is good. B, yes, but only in the future. It's not there yet. Or it's not a toy. It's a toy, not a tool. Okay, it's a toy. Okay, this is a toy. It's okay. Okay, the last question. How do you judge the 3D printing approach? Useful to increase the success rate of occlusion? In additional anatomical information to reduce complications? Not very crucial. The current imaging modalities already guarantee high success rate and a good safety margin. I have a presumption on the answer, but I'm interested. No answer.
Can we have the answer?
I think we can stop here. I mean, just maybe just since it's a toy. I mean, we're probably. I mean, just not very crucial. I mean, no one has answer. Okay, thank you.